Welcome to the DocTalks Podcast, a conversation on what's new and relevant in the world of Canadian medicine and hospital healthcare. I'm your host, Ian Gillespie, and I'm here to ask the questions and find the answers you need to know. We want to help our listeners know how to prevent and detect illness and how to navigate our healthcare system. Be sure to subscribe to the DocTalks Podcast to stay up to date on new episodes, and follow us on Twitter at St. Joseph's London, or visit sjhc.london.on.ca/podcast. Hello, I'm Ian Gillespie. Welcome to the DocTalks Podcast, brought to you by St. Joseph's Healthcare London. In Canada, falls are the leading cause of injury-related hospitalizations and deaths among people aged 65 or older. Half of those falls occur at home, and the most common injury from a fall is a fracture. Today, we'll be delving into this topic, and I'm talking to Dr. Jaspreet Banghu, a geriatrician at Parkwood Institute with a specialization in falls assessment, intervention, treatment, and research. And we're also joined by Janelle Unger, a registered physiotherapist and the principal investigator at the RED Neuro Lab, who's currently conducting research at St. Joseph's Gray Center for Mobility and Activity as part of a partnership with Western University. Thanks both for joining us today.
Thanks very much.
Thank you for having us.
So some of the stats here that I'm looking at, falls, as I said, the leading cause of injury-related hospitalization and death. Of course, they reduce quality of life, increase caregiver demands, sometimes lead to admission into long-term care. Do we have a sense, and anyone can jump in, like how common falls are? I know it's sometimes hard to put a number to something like this.
Yeah, so I think classically what we quote is it depends on age. So between the age groups of, say, 65 to 75, you'd expect maybe 1 in 4 to 1 in 5 of the population to fall. That increases drastically, though, when you get at the age group 85 plus, where we expect 1 in 2 of those patients to have experienced a fall. So in other words, 50% of patients over the age of 85 will experience a fall sometime in their lifetime. So it really is age dependent.
Of course. And can we talk about then, there's a host of different risk factors, from illness, dementia, vision, muscular weakness, footwear, so on and so forth. So can we talk about some of the biggest risks that you see that lead to falls amongst elder Canadians?
Yeah, definitely. So from a research perspective, we like to look at things using what we like frameworks. And so the framework I typically use is the systems framework of postural control and balance. That looks at the different systems mostly related to the individual themselves. So some of the things you've already mentioned, like vision, if they have any changes in their sensation or their body awareness of where they are, that can be a huge cause. Looking at things like cognition. So are they able to pay attention to more than one task at the same time? So a lot of those systems are within the individual themselves. But then, like you mentioned, there's tons of environmental factors as well, which are difficult to tease apart sometimes. So looking at things like the home environment, big risk factors we see there are people using throw rugs or, leaving items on the floor. If people have pets, they can leave toys around or they can be a tripping hazard themselves as well. Living in Canada, obviously we have winter, which is a huge risk factor, creates icy sidewalks and driveways and things like that too. So it's really difficult to pinpoint one exact thing that's the leading cause for falls, as they are often multifactorial, involving both some factors within the individual and then some of those environmental risk factors as well.
Right. And at least, I guess, in many of those cases, we can do something about that. So, for instance, as you said, environmental factors, making sure, as you said, there's no throw rugs, picking up a stray electrical cord. Any other advice you have there as far as just in the home? I guess installing grab rails or handrails at some point?
Yeah, definitely. So anything with like stairs, tubs, showers, we often recommend putting in grab rails and handrails. Definitely keeping the floor free of clutter and cords, like you mentioned, picking up items after, if it is after pets or kids or whatever you have around. And then just little things. Something that I used to see frequently was people getting up at night maybe to use the washroom and not turning on any lights because it's night and you're trying to stay half asleep, but that can be a huge risk factor as well. So installing like low level night lights can be really helpful for some people. So there's some level of vision, even in the dark, just some of those little things at home. But really the big things we're looking for are removing clutter from the floors, I would say, is one of the big things.
And Dr. Banghu, again, another stat I've got here that 39% of injuries from falls are fractures. So maybe you can address that. I assume, well, I don't know. I'll ask. Are we talking about, you think hip fractures? That's what I think of.
So, yeah, hip fractures are the ones that are most feared. What we have started to divide them into, though, we started to call them what's so-called fragility fractures. And the reason that we talk about that is it really gets to the point of the fact that the bone itself has become more fragile and therefore is more liable to breaking. So the one that everybody fears is the hip fracture, which is possibly the most common, but also possibly because other types of fractures may go unreported or unnoticed for a long period of time. But the other type of fragility fracture that we worry about is a wrist fracture. And that is another quite a common occurrence, especially if a patient is falling and puts their hand out to stop any impact. That can itself result in a fracture. And a lot of what we try and make sure to do is try and assess how fragile the bone was to have broken in the first place, and then whether or not we can make meaningful changes, usually with medication, also with nutrition, to try and make that bone less fragile and try and prevent it from breaking again in the future.
So we're sort of bleeding into osteoporosis, I guess, are we?
Correct. And when Janelle and myself were talking about creating a joint clinic, one of the names we were coming up with, because we wanted to incorporate osteoporosis, was a falls and fracture clinic. And that's what a lot of falls clinics are named now, is a falls and fracture clinic. And in fact, we added the word frailty because that just denotes what's going on. The fact that all of these things are linked and that all of these things combine at the same time. So an older adult who, as Janelle had gone through, has a number of risk factors, may have had a fall that then led them to break a fragile bone. And all three of those things are what we're trying to prevent if we can. And if it has already happened, to try and help repair and rehabilitate in the future.
And then I guess some of these injuries can not only be physical, what am I trying to say here, but psychological consequences as well. Is that maybe someone could touch on that?
Definitely, there's a lot of psychological consequences along with having a fall. So we see things like embarrassment or shame, especially if the fall happens in a public setting. People, can be quite embarrassed that it's happened and they want to get up very quickly, even if they might be injured and maybe need some more medical attention, but they sometimes just want to remove themselves from the situation as quickly as possible. But then the other big thing that we see, and we're trying to target a lot in research, is what we call the fear of falling. And that's really become its own concept now. We see that people who do experience falls develop this fear of having another fall, which can reduce their level of participation in activities. Maybe they don't want to leave their home, especially if the weather's not good or something, and they reduce participation in social activities. They might reduce their level of mobility. So maybe they are able to walk and move around, but they might select to use a scooter or a wheelchair or some form of a gait aid because they're fearful of experiencing another fall, which actually then just kind of perpetuates the cycle, unfortunately, and leads them to be more at risk for future falls. So really getting ahead of that fear of falling is important. So like Jaspreet mentioned, we do see individuals that have experienced a fall, but what we try to do is with rehabilitation, with, medical changes, whatever we can do from both of our perspectives, try to help those individuals realize that we can kind of maybe prevent future falls so we can mitigate some of that fear of falling, because we have seen that it has really negative consequences.
So fear, the psychological aspect of fear, and I suppose obviously that can lead to more medical consequences, correct? I mean, people are withdrawing from life, I suppose, in many ways and getting less active. And
yeah, it's one of the feared consequences is that patients will start to develop a negative cycle, where it's almost like a negative feedback loop is sometimes what we call it in scientific circles, where you have had a bad, probably traumatic incident in both psychological and physical terms. You fear having it happen again, so you no longer are as active. You don't carry out the same activities that you previously did. And when you're talking about walking as being the activity that you no longer carry out, you all of a sudden become more sedentary. And we get into that perpetual negative cycle where you have somebody who becomes more sedentary, they lose that muscle mass, that flexibility, and the freedom of walking, and become more socially isolated. And all of a sudden that fear gets worse. That fear of falling that Dr. Unger had talked about becomes worse, and that reinforces itself. And they are therefore more prone to falls. and their bone health and nutrition can get worse. Their cognition can get worse. And that's the negative feedback loop that we are always trying to break. That's really where rehabilitation would play its part, is to try and break that feedback loop.
Right. And then again, these sort of questions, I mean, obviously it depends on the individual and there's so much variety, I'm sure, but rehab involves, I guess, depending on the age of the patient and the circumstances of the injury, correct?
Yeah, definitely. I would say from a physio perspective, we're always trying to add in whatever level of mobility makes sense for that individual. So if they are able to be up and out and walking in the community, then we would definitely encourage higher levels of activity. For some individuals, even just doing exercises in the bed or in sitting can be really, really helpful to mitigate some of those effects that Dr. Banghu is mentioning of muscle loss and bone health and things like that. So we do have to target it to the individual's capabilities, and we try to push individuals from a rehab sense, but really targeting sort of any physical activity, exercise, mobility that's appropriate for that individual would be the focus from the physiotherapy perspective.
There's a lot that we can do as well from the medical perspective. One of the big things that I'd like to touch on, if we have a second, is about medications. And we have a name for them in medical terms in geriatrics called falls risk inducing drugs. And these are drugs that basically lead you or make you much more likely to fall in the future. And if you did fall, they make your rehabilitation less likely to be successful. And these are commonly prescribed medications, things that can cause any type of sedation or sleepiness. So these are sleeping tablets. There's a class of drugs called benzodiazepines. One of the more famous ones is something like Ativan, which is a drug that people sometimes are prescribed to help them relax. Xanax is a more famous kind of pop culture one that sometimes gets used as a drug of abuse to help people relax. These types of medications, the danger is that they make you too sleepy. And for an older adult, especially if you are in that negative cycle that I was talking about, the negative feedback loop where you're not going out as much, you're more sedentary, you're scared of getting out. Maybe somebody thinks, oh, well, you're over anxious, therefore I will prescribe you a drug to help with this. But what they're doing is making you more sleepy. And your ability to participate in activities like rehabilitation are reduced. And if you are walking, it is more likely that you are to fall because your reaction time has slowed because you're sleepy. So a lot of what we look at, a lot of what we do in geriatrics, especially on the rehabilitation side of things, is looking at medications that could be increasing the risk of somebody falling and adjusting those medications and trying to put them on different drugs to reduce that risk in the future.
Is that something that you think most family physicians, I assume if the patient has a physician, when they're prescribing these sorts of drugs, I guess they must take into account these sorts of effects, right? But I guess should they be more aware of the possible consequences of some of these drugs as increasing the risk of falls?
I think we should all be more aware as prescribers that everything we prescribe has, I always say in an older adult, there's no such thing as a free lunch. And the drugs, unfortunately, can have side effects, and even minor side effects can be enough to cause somebody's balance or their awareness to change to a degree where they're more predisposed to a fall. So yeah, anybody who is a prescriber and is thinking of these medications should do so with caution. Or if you're a caregiver and you are looking at mom or dads, or maybe it's aunts or uncles or grandmother, grandfather, and you're looking at their medications saying, hold on a second here, these medications were prescribed a few years ago for relaxation, but now mom's sedentary all the time. Maybe we should be having a look as to whether these are appropriate for her still.
Right.
And that's usually what we try and do, is prompt people to say, maybe I don't need these medications anymore. Maybe these medications are actually causing harm. Maybe we can find better ways to do this.
And I don't know I'm sure that some of the medications, sort of like blood pressure and so forth, will lead to dizziness and lightheadedness, right? Which is another factor.
Yeah, it's a double-edged sword with the blood pressure medications, in that a lot of those medications, we put them under what I call a secondary group of medications, where they are usually prescribed for a good reason. So blood pressure is still something we need to treat no matter what age you are. And a normal blood pressure is really what we want to get you to no matter what age you are, because it's protective for so many other ways. But unfortunately, too much of anything can lead to side effects. So we do have to try and be judicious and be careful that we prescribe in different ways for different adults. So if you have somebody who is falling a lot, who is frail, perhaps you would reduce down their level of blood pressure medication or heart rate control because that's more appropriate for them. And that can be really difficult because, having somebody that's able to evaluate what dose you should be on, what dose each individual should be on, can change over time.
Is there a role for pharmacists or drug dispensers in counseling customers as to how the side effects of a drug and how that might increase the risks of a fall?
100%, and there's a lot of good evidence in other countries such as the Netherlands, where they've looked at getting prescribers, whether they be, or even dispensers as they are in Canada, getting people like pharmacists who can prescribe it in some jurisdictions to counsel patients more in a more wholesome fashion, and to really focus on falls risk prevention in older adults, to say, well, this drug is actually really dangerous for a fall in the future. Maybe we should reduce the dose. Maybe we should not put you on it at all. Have you talked to your doctor and or other prescriber about it in the future? So whether that's done by a pharmacist, a nurse, a loved one, a generated AI bot, whoever, I think is all a positive way.
And Janelle, I think in the intro here, I wrote that you're looking into interventions to improve gait and balance. Can you talk a little bit about that research?
Yeah, I am a physio myself, but I do research now full time. And I come from a background where we use biomechanics. So we use instrumented techniques basically to look at how the human body moves. So I do very, sensitive tools that can measure gait and parameters and walking speed and things like that at a level that we just can't do clinically typically when we just have, our eyes and a stopwatch and things. So one example is using inertial measurement units or IMUs, which is something that I've partnered with Dr. Banghu to use in the clinic he was mentioning earlier. And what that can do is give us really specific levels of detail about someone's walking, their standing balance, so many different factors, really. And so the research that we're doing that's a measurement tool where we can look at how someone's moving. And that's where we're starting right now. We're starting in the clinic, looking at how people are moving. And the first step is really to try to see if we can use those different measurements to predict who might be the most or the highest risk of a fall. And what we're hoping to do as we move forward with the clinic is to look at how we can triage people based on that fall risk and send them into different streams of rehabilitation. So some individuals may benefit from really intensive rehabilitation for a couple weeks to get them back into a good place. Some individuals may already be doing quite well and maybe could benefit from a home exercise program or a community referral or something like that, with then a subsequent checkup scheduled with the clinic itself. So the first thing that we've got to do is figure out if we can predict kind of who's at risk for falling in what time frame, and then from there triage them to different rehabilitation streams, which are typically focused on sort of activities of daily living training. So working maybe with an occupational therapist for that, working on exercise and physical activity with a physiotherapist. I think that they might do some cognitive training. That would be something that could be very useful for somebody if they are having difficulties with memory or attention or things like that. So first identifying what those risk factors for that individual are, because we know they're so varied, and then trying to target them more specifically with different streams of rehab.
You were mentioning how activity, of course, is so important just to health and the prevention of falls. But say, for instance, someone who's confined to a chair or a bed, are seated workouts beneficial?
Absolutely. 100%. I would encourage any type of exercise, activity, mobility. Definitely, if safety is a concern and that individual is not doing it under supervision, seated exercise would be safer to do at home by yourself than a standing balance exercise would be, for example. But any level of physical activity or mobility is going to be beneficial. Like I said, even just doing exercises in the bed. Some people like to do some gentle stretching and movements before they even get out of bed first thing in the morning, help kind of wake the body up. Seated exercises are great. Any level of mobility is good. Definitely, we're always trying to push for the highest level of mobility that an individual has available to them and still challenging them. The other piece of advice I always give caregivers and patients themselves is, you don't have to be scared of pushing yourself, right? So you do want to push yourself, you do want to increase challenge, but in a safe way. So you're doing it with, other people around or something stable nearby that you can hold on to if you lose your balance. We're always doing things safely, but we really do want to push people to whatever their limit might be, because that's the way that we see the most improvements is when we challenge the body.
And just on a personal level, as far as the people themselves or caregivers, I would assume, it's an interesting stat here, I saw that marriage protects against falling in patients over 80. So I was just going to say, I assume that living alone is an added risk, yes?
I would imagine that's kind of what that stat is interpreting. Having someone else in the home would probably be protective. I don't know if it needs to be a partner necessarily, but having someone else in the home, I would imagine, does have a protective effect. And also, there's a lot of cognitive benefits to living with other individuals. So, someone to have conversations with and things like that, too, can be really helpful.
And I guess we sort of quickly went over some of the preventive factors early on, right? Maybe we can address them again. I mean, so maybe just start with the environment again. If we look at environment, what are some of the main things that people can do to reduce the risk of a fall?
Yeah, so I think we mentioned earlier some of the things like handrails, guardrails, removing items from the floor, throw rugs, things like that. If there's a slippery surface, such as a tub or a shower floor, having a grip mat or something like that can be really helpful to reduce kind of that slipperiness. Some people might prefer to sit in the shower, right? So getting things like shower chairs or things like that. Raising the height of seats to sit down on. So raising the height of toilet seats or even raising up furniture to a taller height can just make it easier for individuals to sit down and stand up, which then can help reduce the risk of them falling during a sit to stand type activity. Removing clutter, wearing shoes in the house is one that I often recommend, or a firm soled slipper. So nothing that's too flimsy in the house, want something with a nice firm sole. Having a pair of indoor shoes is often something we recommend for fall prevention as well. Definitely not going around in sock feet, because that can increase the friction then on the floor. So those are some of the things that we would recommend from an environment perspective, from a physio standpoint, for sure.
Right.
And from a medical standpoint, quite rightly mentioned that blood pressure is something that we look at. Blood pressure that's too low can cause dizziness and can lead to falls. We know that. Heart disease as well. We always want to look for evidence of specific underlying heart diseases. One of them can be something called aortic stenosis, which can cause the blood pressure to drop quite quickly and contribute towards a fall. We also want to make sure that a patient doesn't have an underlying cardiac disorder or a heart rhythm disorder where their heart might go too slow for periods of time. Those are all things that we look at when we're evaluating whether somebody with a fall has something else that we can prevent. And the other part that we look at when somebody comes in is making sure that we've really thought about the control from their brain. And what I mean by that is, as Dr. Unger has touched upon, their cognition or their memory, is that all normal? Do they maybe have a disease that we haven't diagnosed yet that may be leading to them becoming more unbalanced? And is that something that we can actually intervene upon? So those are all, from a medical point of view, that's the sort of workup we like to look at when patients come to see us.
And I suppose that as the population continues to age, are we seeing more falls, Dr. Banghu? Are they increasing? Are the numbers getting worse?
It's a definite yes. I just looked up the statistics as well from Stats Canada, and year on year, the number of falls that older adults experience has gone up. What's frustrating from a practitioner's point of view is the length of stay. So if you're over 65 and you have to be admitted because of an injury related to a fall, the average length of you staying in hospital is about 2 weeks. And that hasn't budged in about 30 years worth of statistics collections. So despite medical breakthroughs, despite lots of infrastructure investments in terms of, alternative care beds, a lot of infrastructure based on trying to improve discharge situations, falls-related injuries, usually if you end up getting admitted, you're in for about 2 weeks at minimum. And that's the average length of stay. And that's something that we would really love to see going down in Canada, because that's a real marker of how we're doing with regards to falls prevention.
Segueing then into what you're looking at in the future. Dr. Unger, you were talking some about your research, but are there any new developments, either of you, maybe we'll start with Dr. Banghu, in terms of rehab or treatment on the horizon?
A lot of what we're trying to do is coordinate care in a better way. And
Right.
it doesn't sound all that innovative necessarily or novel, but it's really doing the small things in the right way. And that's a lot of the reason that myself and Dr. Unger, would work together is even just combining her knowledge with the external risk factors that she discussed. I don't understand those external risk factors as well as a physiotherapist does. And so she's able to really combine that expertise with the expertise of a physician who's able to look at those risk factors like medications and heart disease in a more wholesome fashion. Being able to do that in a systematic way is the only way forward for falls prevention, because there's no one drug that's going to come out one day and change this. There's a coordinated effort, though, that can actually lead to patients getting the right types of therapy with the right expertise, and making sure that that expertise is combined to try and personalize a treatment schedule for patients.
What we're really realizing is that no two falls, even within the same individual, are the same and are probably due to the exact same reason. And so it's really hard to come up with one solution for falls when falls are so multifactorial and so individualized. So I think that's what the research that we're trying to do with the partnership that we have and in the clinic that we're running right now is, can we start to systematically predict, which risk factors are most likely lead to a fall, or is it a combination of certain risk factors? And then are there different types of falls? So are there falls due to a primarily cognitive driver versus a primarily muscle weakness or imbalance driver, medication use, and see if we can start to kind of piece this out a little bit more in depth and not just look at falls as one big concept, because there's so many different things involved. So I think if we can start to tease that out, then again, we can try to create targeted interventions and rehabilitation streams for specific categories or types of falls or risk factors for those falls. But that does take a really concentrated effort from all individuals involved, including the patient and their caregivers, because they're the ones that see them all day, all the time, and see how they're moving and how they're interacting with their environment, and if they're taking risks with their behaviors or not too. So I think it really takes a team effort here for us to try to figure this out. And I really do think we need to look at falls as more than just this one big concept, but really start to look at some more of the details involved with it if we're ever going to move forward with prevention and solutions for that. The other thing I'll say as a physio is, at this point in time, we know falls are somewhat inevitable. And so also just training people on what to do after the fall is really key. People don't like to talk about that they might have a fall and what to do, but it is really important from a rehab standpoint that we are training people how to fall properly. So maybe we can avoid some of those fractures they might come in with. And then also, how then after they've had the fall, to how to assess themselves to see, do I need medical attention? Do I think something is broken, right? How to assess themselves, and then how to get back up off of the floor, or if they need to call for assistance to get back up. Because sometimes we can see secondary injuries come from an individual trying to get themselves up when maybe they needed some more help or something. So I think the piece of it that we're missing right now is really that education post-fall, because as rehabilitation professionals, we know that they are likely to happen still. We haven't quite figured out that prevention piece 100%. So we're still working on the prevention, but in the meantime, we also need to teach people just what to do in case they do have a fall, so that they can, hopefully avoid that hospital stay that Dr. Banghu mentioned, and then again, learn from the fall and try to prevent future ones.
I have to ask then, there's a way to fall, a sort of better way to physically fall?
We can talk a little bit about that. Sometimes in rehab, often the wrist fractures are from putting the hands out, which is good, right? It protects the head. Usually that's our end goal, is always protect the head. But just looking at, if people feel that they're about to fall, we can even talk about sort of reactive strategies, taking steps or reaching out for things. We can practice those in rehabilitation or in physiotherapy. So we can practice some of those protective strategies with the clients so that they can work on their reaction time and things like that to maybe prevent actually falling all the way to the floor. But usually it usually does come down to trying your best to protect the head and the neck as much as you can. And sometimes that does end up with a different fracture, like a wrist fracture. And we also try to avoid falling directly onto the hip. So if an individual feels they're falling to the side, then anything they can do to get an elbow down or something like that can help protect the hip from making that really harsh contact with the floor, which could result in the hip.
Dr. Banghu, is there anything else that we haven't touched on that you want to just mention before we close?
I guess the other part to highlight for anybody who's caring for somebody recovering from a fall or a hip fracture is to say that it is quite a difficult journey for the patient. They have a lot going through their heads. I think if anybody was to say what one of the greatest fears is, it's getting to a point where you can't control your body anymore and it falls and you feel like you've lost that control, and it's almost a sign of getting older and of the inevitability of what comes with what happens when we get older. So I guess it's a long-winded way of me saying, to have some patience with your older adult, to try and help them through some of the rehabilitation processes, because they're painful physically, mentally, emotionally. And then as a caregiver, to consider yourself in it and to make sure that you're getting enough time, and making sure that you're also caring for the patient in a time where you're feeling up to helping them with their exercises and helping them with their activities, rather than trying to stress yourself to the point where a relationship might break down between you and your loved one. So I think it's just a message of public health, to be honest, because falls really is one of the number one public health problems for older adults.
All right. Well, certainly thank you both, Dr. Banghu, Dr. Unger, for shedding some light on this very, very common problem, and I'm sure that listeners will benefit from us. Thanks again, both of you, for joining us today.
Thanks a lot.
That's it for this episode of the DocTalks Podcast. Thanks for joining us, and join us next time when we'll continue our conversation on what's new and relevant in the world of Canadian medicine and hospital healthcare. Be sure to subscribe and follow us on Facebook and Twitter at St. Joseph's London, or visit sjhc.london.on.ca/podcast. Until then, stay healthy.